Good evening, everybody, and welcome all of you to the live program number 110, Orthopaedic Principles. We are back with our exceptional faculty, Dr. Saurabh Agarwal from the Princess Royal University Hospital, London, United Kingdom. Dr. Agarwal has given 3 previous lectures and they've reached to a lot of people around the world and they're well appreciated. Today, Dr. Agarwal is going to enlighten us on upper limb neuropathies and tendon transfers. Over to you, Saurabh.
Yeah. Thank you, Dr. Hitesh, for your kind invitation. Always a pleasure. And thank you, everybody, for taking out your time and for your kind attention. So, this is my hospital, Princess Royal. It's sort of in London, and I'm a trauma and upper limb surgeon. So our topic today is upper limb neuropathies. I'm going to talk a bit about anatomy, tendon transfers, but because it's a huge topic, there are 6 nerves to be done, 6 sites of compression. So I've divided it into 2. Today, we're going to do cubital tunnel, Guen's canal, and carpal tunnel with all the relevant tendon transfers. And then in the next lecture, we'll cover the remaining of the nerves. So we'll start with cubital tunnel. Now, this topic is important for few reasons. One, if we have a knowledge about the anatomy of nerves, then operation becomes easy. 2, these are quite bread and butter topics: ulnar nerve decompression, median nerve decompression. We all of us do them at some stage in our career. So I thought sort of we'll touch on these nerves and topic today. So let's start with ulnar nerve. Bit of anatomy, as I said. It comes from a medial cord of brachial plexus. We know that. And if I take you there, that's the medial cord, that's posterior, that's lateral. That's the ulnar nerve. So in the exam, you will be asked or can be asked to draw a brachial plexus. So which should take you roughly 30 seconds. So that's why I put this slide. So ulnar nerve, and then ulnar nerve is a very twisty nerve. For example, radial nerve, it loves bones. It's in close contact with spiral groove, then in close contact with radial neck. Ulnar nerve, on the other hand, takes a very sort of a bendy, twisty course. So behind the elbow is in the posterior compartment, behind medial epicondyle. Then it pierces 2 heads of FCU, and then it comes in the front, in the volar side of the forearm. And then obviously when it's in the wrist, as we know, it twists around the hook of hamate and arches all across the hand. So it takes a very bendy, twisty course. It doesn't have any muscle supply, any branches in the arm. But as soon as it, or before it pierces FCU, it gives a branch to FCU. And then in the forearm, it gives a branch to flexor digitorum profundus, to the ring and little finger. And then just before the elbow, a couple of centimeters above, it gives a cutaneous branch, which supplies a dorso-ulnar hand. Then it enters into Guen's canal. And as soon as it goes distal to hook of hamate, it divides into a superficial and a deep branch. Superficial, as we know, is sensory to 1.5 fingers. Deep branch supplies all the hypothenar muscles, abductor pollicis, abductor digiti minimi, opponens digiti minimi, flexor digiti minimi. Then it supplies 3rd and 4th lumbricals. It supplies adductor pollicis, palmar and dorsal interossei, and it also supplies half of flexor pollicis brevis. So, so important here is this cutaneous branch. Why? Because neuromas to the superficial radial nerve and the dorsal cutaneous ulnar nerve, they're very disabling, because if you're putting your hands in a pocket, you're shaking hands, your hands are touching all the objects. So these neuromas are really disabling. So anytime there is, you do any surgery close to ulnar head and neck, be aware of this cutaneous nerve. It's very important. Other thing to remember with FCU is rule of thumb. Any nerve which pierces a muscle supplies the muscle before it has pierced the muscle. So the branch to FCU is given before it has pierced it. Similarly, median nerve, before it pierces pronator teres, it will supply that muscle. Similarly, posterior interosseous nerve, before it pierces supinator, it gives a branch to them. And I've got all those slides where I'll show you how it's supplying those muscles before it pierces. So now that we know a bit about ulnar nerve course and its branches, let's go to the cubital tunnel. So ulnar nerve can get compressed in the intermuscular septum, arcade of Struthers. So ligament of Struthers for median nerve, arcade for ulnar nerve. Then it can get compressed. This is Osborn's fascia. So just behind it, it can get compressed as it pierces two heads of FCU. And then there are other reasons, any trauma, elbow dislocations, supracondylus, any other fracture dislocations, tardy ulnar nerve palsy, and lateral condyle fractures. So those are the ones we need to be aware of also. Then of course, ganglions, lipomas. So there are a lot of causes which you can talk about in the exam. In terms of presentation, so sensory and motor. Sensory, as we saw the sensory supply, is going to be 1.5 fingers, ulnar side. And the autonomous zone, you need to remember, volar pulp, little finger. For completeness sake, I put here 2-point discrimination and Semmes-Weinstein monofilament test. They're very relevant and important in diabetic foot, but you need, in case they hand you a monofilament, you need to know a bit about it. In terms of motor examination, important is so all the interossei will be wasted, but in an early ulnar nerve involvement, look at the first web space, because that's where you can clearly see wasting. So even in early wasting, first dorsal interosseous being such a big muscle, you'll be able to pick up the wasting. Then of course, Wartenberg sign. So if you see the picture there, what it essentially means is, if you ask the patient to adduct the little finger, because palmar interossei is not working. So what will happen is, instead of finger being adducted, extensor digiti minimi, as you can see there, it contracts and finger goes into extension rather than adduction. Froment sign, again, because adductor pollicis is not working on attempted adduction, patient will use flexor pollicis longus, which is supplied by anterior interosseous nerve, as shown here, to hold on to a piece of paper. So that's your Froment sign. Clawing, because again, we know ulnar nerve supplies third and fourth lumbricals. So if those are not working, lumbricals, as we know, flex at MCPJ and extend at IPJ. So if they're not working, the extensors will cause hyperextension at the MCPJ, and there's a reciprocal flexion to the IPs, hence the clawing. Tenels, again, like with any nerve, if you irritate the nerve, patient will have paresthesia. So that's your Tenel sign. Remember, you should do Tenels right at the end, because once you've irritated the nerve, whatever you do, symptoms will be positive. So like, for example, in a carpal tunnel, do your Phelan's first, do your Durkin's test first. Tenel should be the last test to be done. Then ulnar nerve stretch test. Idea is to ask patient to flex elbow with wrist extended. Ulnar nerve will, you're lengthening the nerve, it will get irritable and they'll get paresthesia. So other little tip is, always do a sensory examination first, because it's a very quick way to know if the nerve is involved or not, for any nerve examination, followed by motor. So once you establish that, in terms of management, like with anything, of course, you're going to get your nerve conduction studies. And if it shows mild or moderate, try splints and activity modification. So splints mean, and I do this way quite often practically, like if a patient sleeps with a bent elbow, so it's like a ulnar nerve is stretching, like ulnar nerve stretch test. So a simple advice that sleep with your elbow straight. Don't bend your elbow when you're sleeping. And you can give them splints to keep elbow straight, extended. So those simple things, they help a lot. Activity modification, people who lean onto their elbow onto hard surfaces. So tell them to use a cushion. So all those little changes make a big difference. And in mild cases, 80% will, you can get away without an operation. 20% will need surgery. Moderate, around 1/3 will need surgery, but 2/3 you may escape without operating. Surgical indications, of course, if it's a severe nerve compression or muscle atrophy. For any nerve, if you see any muscle involvement, dorsal interosseous wasting, then that means we've already missed the boat. That means nerve is compressed, severely compressed. And the longer you sit on that nerve, more muscle compression, more muscle wasting will happen. So that's an indication to operate. In terms of surgical management, now sort of you can be asked as to the choices. So one is a simple decompression, open or endoscopic, and you can combine it with medial epicondylectomy or an anterior transposition. Anterior transposition can be subcutaneous, inside the muscle, or submuscular, which we're going to see in the coming slides. So simple decompression. So setup is supine, arm board. I put a tourniquet with a side table. That's the marking. Olecranon, medial epicondyle, nerve goes just behind the epicondyle. And these are the structures you're going to release. So I'm going to show you some operative pictures to try and make some sort of sense out of it. So skin fat, that's the Osborn's fascia. That's the ulnar nerve. First tip, practical tip, where do you identify ulnar nerve? So for your elbow replacements, for your distal humerus, double or triple platings, for your cubital tunnels, the best place to identify ulnar nerve is next to the medial triceps. That's triceps, medial border. So roughly 3 centimeters, 3 to 4 centimeters above the tip of medial epicondyle. That's where nerve is the easiest to locate. And this is very helpful in trauma situation, very helpful in revision ulnar nerve situation. So that's the first thing to remember. And to divide Osborn's ligament, I've just shown with the Mackendo, but put a McDonald's like in a carpal tunnel, and then with a knife you can divide the Osborn's ligament. And then once you've divided, you'll see the nerve, and you can already see, look at the difference between the nerve quality there and there. Here, distal to the compression, nerve is very dull. It's a bit atrophied, and there's a bit of congestion here. So always, once you've decompressed a nerve, look at the quality of nerve, and always comment in your notes and mention that in the exam as well. And then, so again, you can see much more better here, triceps, ulnar nerve, and you're going to see the intermuscular septum a bit better here. So that's the medial intermuscular septum, and we're dividing it. Second thing to remember, if you ever decide to transpose ulnar nerve anteriorly, then you have to excise this 2 centimeters of intermuscular septum. You don't need to excise all of it in its entirety, but just couple of centimeters here, so that nerve doesn't flick on it after anterior transposition and doesn't get irritable. So this is after division of intermuscular septum. And then finally 2 heads of FCU. Again, you can put a Mackendo there and then divide the 2 heads. That's the, so 2 heads are, one is humeral head, this is the humeral head, that's the ulnar head. And again, as I was saying, look at the quality of nerve, quite dull, atrophied. Compare this to this. So always make a note of how the nerve looks. And then this I've just included. Very occasionally I'll see these cutaneous nerves. More often than not, I don't. If you see them, obviously preserve them, because they are a reason why sometimes patient can have persistent sort of pain to the sort of near the scar area. And this is the branch of FCU. motor branch. So you can see it's just given off before nerve pierces FCU. Always try and locate it and preserve it. And then once you've done that, once you've done your decompression, then idea is to see if the nerve is flicking over medial epicondyle. So flex and extend elbow. And if the nerve is flicking, then you need to anteriorly transpose it. Now, one tip to keep nerve stable is when you're decompressing, do not decompress on the tricep side. Decompress on the anterior side. If the nerve stays with triceps, it stays stable. Plus the vascularity is also preserved. And then, of course, if you have to anteriorly transpose it, nerve can go there. You can see very nice fat here. Sort of put the nerve here. So make a fat flap, put a nerve, and I do 3 stitches, 1 pocket, 2nd pocket, 3rd pocket. So, so that's how I would do a subcutaneous anterior transposition of ulnar nerve. Then medial epicondylectomy. If your X-ray suggests your medial epicondyle has spurs or it looks a bit prominent, then we can partially excise it. You cannot completely excise it because your MCL is attached just inferior to the epicondyle. So that's the cross section, that's your epicondyle, that's the nerve. So all we need to do is if we partially excise it, nerve won't get irritable. So these are again some operative pictures. That's ulnar nerve and that's epicondyle. So it's a subperiosteal excision. Periosteum is elevated. Then we are partially excising it. And this is how it looks. So that's after excision with a bone wax, and basically a nerve is not going to now get irritable over the epicondyle. Anterior transposition. Now, so again, anterior transposition in sort of my practice is a very occasional thing. If I do 20 nerve decompressions, maybe in 1 or 2 cases. So what are the indications? Cubitus valgus, so for example, lateral condyle, very common scenario because it's the 2nd most common injury in a child. And if it's a Salter-Harris 4 injury, then we know it can cause growth disturbance. Elbow goes into valgus, ulnar nerve stretches out, tardy ulnar nerve palsy. So these are the ones, if we take ulnar nerve in the front, we're preventing that stretch, and that will help. So that's one reason. Then 2nd reason we've already discussed, after any decompression, you should check for, do flexion extension check if the nerve is flicking or not. Elbow replacement. Not always, like we did an elbow replacement last week, but we tried to, we got away without transposing it. So in some cases though, you will have to transpose it anteriorly. Same with Orif distal humerus, you don't need to transpose in every case. But in case your ulnar plate is prominent or you think your nerve is rubbing on it for some reason, you're not happy, then you need to transpose it. And transposition, as I showed you here, make a nice flap of this fat and then put the nerve in between 2 layers of fat and 3 pockets, 3 stitches. And this is at least how I would do it, but there's no right or wrong. You can do it in your own sort of style. So then finally submuscular transposition. I've never done one. I've got some slides of my colleague. Basically, this is how it's done. That's ulnar nerve. This is all your flexor origin. We know Z lengthening from our Dupotrons. And then lift the flexor muscles. Ulnar nerve will come in the front and stitch the muscle back on. That's your submuscular transposition. If you do a proper submuscular transposition, your ulnar nerve is very close to the median nerve. So it's not an easy operation to do. Remember that. So before we go to Guen's canal, or let me finish. Before we go to Guen's canal, let's do the tendon transfers first. So important is we know clawing, we know why it happens now. So we need to restore the claw hand, and then your interossei, they are responsible for your abduction, of your index finger. So it's responsible for this thumb pinch. So we need to attach something to the first dorsal interossei, and then your FDP. We need to get your DIP, little and ring finger flexion back. So these are the three tendon transfers we need to know about. Now, before we go there, lumbrical muscles. This is very important. I was saying we'll talk a bit about anatomy also. So lumbrical muscles, they're very fascinating muscles in the hand. In the sense, we know they originate and insert on a tendon. So they come in zone 3 of the hand. They're going to come from the radial side of flexor digitorum profundus. Then they go radially, MCP, and inserts into the dorsal expansion, further distal to the interossei. So if you watch carefully, they're coming from the flexor side, but inserting onto the extensor expansion. So this is why they are able to coordinate flexion and extension. And if your hand goes from full flexion to full extension, lumbricals will have a very long excursion of almost up to 2.5, 3 centimeters. Now lumbricals, we know they flex MCPJ and they extend PIPJ along with palmar and dorsal interossei. But the most important function of lumbricals is to stabilize MCP joint. So once your MCP is stabilized, then your PIP and DIP get a stable platform to work. So amongst all the intrinsic muscles, it's the lumbricals which are most important. Palmar and dorsal interossei, their main role is abduction, adduction of fingers, which is not that important. So please remember this point. And so if you understand this, so this is what intrinsic muscles are doing. So intrinsic tightness means this action will be more pronounced. Patient will not be able to do this. So if someone has an intrinsic tightness, if you release the lumbricals here, so just a radial cut on the MCPG and just incise the muscle, that will do away with the intrinsic tightness. So in the exam, if you are asked about intrinsic tightness, it's very easy to explain and very easy to deal with. So the most important intrinsic muscle is lumbrical. So to me, this is the most important slide for this whole lecture. And then other thing is hand compartment syndrome. We know with any compartment syndrome, if you do a passive stretch to the muscle, that's your diagnostic test. So in hand compartment, your intrinsics will become very tight. They will contract. So if this is intrinsics, this is the function of intrinsic. This is where the muscles are contracting. So if I need to do a passive stretch, that means intrinsic minus. So a test for hand compartment syndrome is an intrinsic minus a test. Ask patient to do this. If they can do it without pain, they don't have a hand compartment syndrome. So remember lumbricals, guys, please. So which brings me to the next concept, roll-up action. So I just told you intrinsic stabilizes MCPJ in neutral or in flexion so that IPs can act. So if look at the picture there, if we have to grasp a tumbler, this is what intrinsics are doing. They're stabilizing MCPJ, neutral or slight flexion, and there is a coordinated IPJ flexion, and we are able to hold a tumbler or a glass. As opposed to when lumbricals are paralyzed in a claw hand, in an ulnar nerve involvement or an ulnar median nerve involvement with a total claw hand, see what happens when the same person goes on to pick that tumbler. Because in a claw hand, MCPJs are hyper extended. They're not neutral or flex like this. And lumbricals are not stabilizing MCPs. So the PIP and DIP, they flex very quickly. And with the result, patient is not able to bring the fingers all across the tumbler. And this is known as a roll-up action. You can see there's a big gap here between the palm and the tumbler. And if it was a big glass, big jug, they will hit the jug rather than grasping the hand around it. So that's a roll-up action. So now that we know a bit about lumbricals and roll-up action, so when a patient comes to us with a claw hand, the more important is they're not able to flex fingers or grasp onto objects. So if I give them a splint, which is able to keep my MCPJs in slight flexion, then the flexors to the fingers, FDS and FDP, will work, and they should be able to have a good function. So the other exam thing is a Bovier's splint. So you can be given any Bovier's splint, like this is one, this is another one. The whole principle behind this is to keep MCPJ flexed, which allows flexes to the fingers to work, FDS, FDP to work. And then you get them seen by your hand therapist, who gives them a splint and assess their function. And if the function is good, you see patients in 2 months, 3 months. If they come back and say, oh, this splint made a big difference to my quality of life, then any operation which keeps MCPJ flexed will work. So this splint is very important before you offer a surgery. And it's a very favorite exam question. So basically, these are a couple of papers if you guys are interested. So basically, we are going to use FDS to correct the clawing. I'm going to show you some of my operative slides and I can explain it to you better. So for example, Zancoli lasso technique. So what happens is you take a FDS. Normally, every time we take FDS for any tendon transfer work, I will take it from my ring finger. And before you do that, make sure FDP is working. So once FDP is working, you can sacrifice FDS to ring finger. And see, I've divided it into 4 slips. Divide it into 4 slips for 4 fingers in a total claw hand. And this is your A1 pulley. This is roughly 8 millimeters to 1 centimeter in length if you dissect them in cadavers. So a slip goes under the A1 pulley, here between A1 and A2, come back onto itself, and then keep MCPJ flexed to around 60 degrees. Because we know any tendon transfers, it will stretch out. So MCPJ flex to 60 and then tie this end to this end back onto itself. So again, as I was saying, the whole principle is to keep MCPJ flexed so that your IPJs start working. So that's your Zancoli lasso technique. And then we were talking about interossei. So if you see this picture there, first web space is made of 2 muscles, first dorsal interossei and adductor pollicis. Both these muscles are very powerful muscles of the hand, 2 of the most powerful muscles. And dorsal interossei, as we know, it causes abduction. So it's going to abduct index finger. Adductor pollicis will adduct thumb, and patient will have a good pinch grip, a lateral pinch grip. And for most of our daily functions, we need this. So now this tendon transfer I've never done. So I put some pictures. So APL, you can transfer to first dorsal interossei, or ECRB to the adductor pollicis. Not an easy transfer. I've never done one, but that's the principle if they ask you in the exam. And then finally, because we know ulnar nerve in the forearm supplies flexor digitorum profundus to ring and little finger. Now we know FDP has a mask action. So just in front of the wrist, because my FDPs to index and middle are fine, they are supplied by median nerve. So they were fine. And because FDP has a mass action, just in front of the wrist, sort of 5 centimeters cut, and I can buddy strap FDP tendons of little and ring finger to FDP tendons of index and middle finger. So that's your whole ulnar nerve tendon transfers. So let's go to Guen's canal now. So ulnar tunnel syndrome. Now, I would only do maybe 1 or 2 cases a year. It's not that frequent, but nonetheless, anatomy is important and you can be asked in the exam. So couple of things here: hook of hamate and pisiform, 2 bones to remember. Second, this is an important picture in the sense flexor retinaculum forms the roof of your carpal tunnel. At the same time, because it is attached to hook of hamate and pisiform, is forming the base of Guen's canal, ulnar tunnel. And if you see, the roof is just a small band. So the roof of Guen's canal is very flimsy, other than the proximal band. So once you release this proximal band, you pretty much release the roof. Remember that. Other thing to remember here is when we are doing carpal tunnel, moment we incise flexor retinaculum, we are easing some pressure in the Guen's canal. Remember that. And then finally, look how the ulnar nerve, once it crosses hook of hamate, it divides into a deep motor branch and a superficial sensory branch. Then coming back to the sort of another picture. So there are 3 zones. That's pisiform, that's hamate. So if the ulnar nerve is involved right up to hamate, that's zone 1. It hasn't divided into its branches as yet. So patient is going to have both sensory and motor symptoms. As soon as it crosses hamate, that's the deep motor branch. That's the sensory branch. So zone 2 is motor, zone 3 is sensory. Important thing here is for motor branch, because remember hypothenar muscles are, as we saw, abductor digiti minimi, flexor digiti minimi, and opponens digiti minimi. And then this motor branch goes through opponens pollicis arch. So this is where in the arch it can get compressed. So this is further distal to Guen's canal. Now we were just talking that always do sensory examination first. But remember, in this condition, in a zone 2 Guen's canal ulnar nerve entrapment, patient will have normal sensory symptoms. So you may very occasionally have a patient which has come, but sensory is normal, but there's a marked motor wasting to hypothenar muscles. So don't think if a sensory is normal, ulnar nerve can't be involved. So it's a zone 2 problem, and you will have to release the opponent's pollicis arch, basically. So yeah, this is what I've said here. Basically, zone 1 is before it bifurcates, which is the most common, and you do a Guen's canal release, which we'll see in the operative pictures how we do it. Zone 2 is motor deficit only. This is the one opposite digiti minimi arch. This is the ones you need to remember because sensory is normal, and zone 3 is sensory deficit only. Causes. Causes again. Ganglions, like anywhere else, is for zone 1 and 2. 9 out of 10 cases is the ganglion. That's the culprit, which you can pick up on an ultrasound scan or an MRI scan. Then hook of hamate, that's another thing I see, occasionally 1 or 2 cases in my practice. Hook of hamate, again, if I take you to slide there, if there's a hook of hamate fracture and it doesn't heal, then it can put pressure on the nerve. Sometimes it can sort of the edges are very rough. So at the time of injury, it could have irritated the nerve. Now, so the answer to a non-union hook of hamate will be to excise it. So either we go through the Guen's canal, or you can even go through carpal tunnel, and then through the ulnar wall of the carpal tunnel, you can excise it. I've done it both ways, whichever way is preferable to you. So in clinical practice, ganglions are common, hook of hamate is common. Anomalous muscles, they can happen anywhere in carpal tunnels and Guen's canal. Ulnar artery thrombosis or aneurysm, that's for zone 3, commonly happens in people who drive bikes or motorbikes. Clinical presentation. So we saw this picture when we started with the ulnar nerve. So we're focusing on Guen's canal. So remember, deep motor branch is supplying a lot of muscles in the hand. Abductor, digiti, opponent's digiti, flexor digiti, 3-4 lumbricals, interossei, adductor pollicis, and flexor. Flexor is a thenar muscle, but adductor pollicis is important to remember. Now, other good thing in this picture is, if you see, ulnar nerve has no supply in the arm. In the forearm is just two muscles, FCU and FDP. And then mostly everything, ulnar nerve is all about the hand, as we know that. And that's why for tendon transfers, we spoke about FDP. FCU is a flexor, but we're not bothered because FCR is still there, which is supplied by median nerve. So that compensates for the function. And in the hand, hypothenar muscles, we don't need to do a lot about. Adductor pollicis, I told you about the tendon transfer. First dorsal interossei, I told you about the tendon transfer. And otherwise, abduction of fingers and adduction doesn't matter a lot, as we spoke about. Lumbricals, we spoke about claw hand, and we spoke about Zancoli lasso transfer. So if you remember this picture, it helps a lot with the nerve supply, what muscles it supplies, what tendon transfers you have to do. So coming back to the clinical signs, interossei wasting, we said always look in the first web space for early wasting. Palmar and dorsal interossei will abduct and adduct, so inability to cross fingers or abduct them. Wartenberg sign we spoke about. Ulnar claw hand we spoke about. Ulnar paradox is normally more distal the lesion, less should be the deformity. But paradox in ulnar nerve is more distal the lesion, more the clawing. The reason being, you can see clearly the FDP will be spared and it will cause a flexion of DIPs and result in profound clawing. So that's the paradox. Froment sign we spoke about. And then sensory, we were talking about paresthesia to the ulnar 1.5 fingers. And then, of course, if there are any if vascularity is an issue, there'll be ulceration to the fingertips. Differential for Guens will be anything higher up, cubital tunnel, thoracic outlet, medial cord. Obviously, if it's medial cord, then the cutaneous nerves, the medial cutaneous nerve of arm and forearm, they will be involved. So that's how you do a differential diagnosis. Cervical radiculopathy, again, all the nerve compression signs will be positive. So that's how you can distinguish with cervical radiculopathy. Treatment, again, like cubital tunnel, if it's only mild, splints, activity modification. So as I was saying, for ulnar artery thrombosis and all that, like less pressure on holding on to motorbikes and all that. So activity modification will help. In severe cases, you have to do surgery. And this is very important, decompress all the 3 zones. The reason being, if you just do zone 1 decompression, you're not dealing with the opponent's digiti minimi arch. And if that was also causing compression to the motor branch, patient will not be symptom free. So all the 3 nerves, all the 3 zones. And these are again some of my operative pictures. I was thinking last evening why I did this case. This was a middle-aged woman who had on nerve conduction studies. So she had ulnar nerve symptoms, obviously, but her nerve test didn't suggest a lot to cubital tunnel and didn't suggest a lot to even Guen's canal. Then I got an ultrasound scan, which suggested some problem to the nerve texture behind medial epicondyle. So I decided, okay, fine, I can do a nerve decompression behind the elbow, but she had a lot of pain when I felt her pisiform on palpation. So idea was to decompress both the sides because ultrasound suggested problems with ulnar nerve behind the elbow, but clinically her maximum pain was over pisiform. So I decided to decompress both the sides. That's my incision. So remember, because you have to reach opponent's digiti minimi, so the incision curves quite almost into the mid palm. That's the key here. Otherwise, you'll not be able to access it. And then if you see this picture, so we know the relationship from radial to medial is ulnar artery, ulnar nerve, FCU tendon. And you can see their artery going, and you can just about see nerve dividing into two. And I'll show you the next slide, which shows it a bit better. So that's the nerve, and you can see nerve dividing it. This is the deep motor. That's the superficial branch. That's the hook of Hammett. So ulnar nerve, once it crosses hook of Hammett, divides into two. And there you have to take your scissors and decompress the opponent's digiti minimi arch. So in Guen's canal, it needs a fairly big cut and decompress all the three zones. And she did do well. It took her 4 or 5 months, but in the end, she was symptom free. Other reason for this kind of surgery will be if you have to do pisiformectomy. Pisiform tricutal arthritis. So a simple operation to do is take pisiform out. Or as I was telling you, hook of Hammett, non-union. So it's very easy now. The bone looks at you, you can just take it out. So sort of this kind of operation you'll do for these reasons. Then we'll come to carpal tunnel. So we know carpal tunnel is the bread and butter. We've all done many carpal tunnel decompressions. So that's why this can be asked in the exam. Other scenario is a case patient who's had a carpal tunnel decompression before, but the catch here is he's still got symptoms. So even though you see a scar, there are persistent symptoms which can throw you off a bit. Remember, in severe carpal tunnel, symptoms, numbness only goes away 30-40%. So these are very good exam cases. Someone elderly, post-op, persistent symptoms, to check sort of your examination skills, and then they can go into tendon transfers for severe median nerve compression. So again, like ulnar nerve, let's see the anatomy of median nerve. So brachial plexus, median nerve, if you see here, so it lateral root of median nerve, medial root of median nerve, and they together make a median nerve. So it has contributions from medial cord and lateral cord. Other little things, since we are there, look at the position of brachial plexus, your cords and your subclavian vessel in relation to clavicle. It's in the middle third. It's not lateral, it's not medial, it's middle third. So when you're doing your clavicle platings and putting your screws, especially in the middle third of the bone, you have to be very careful. Subclavian artery is not far away. Coming back to our topic, median nerve. So again, sorry, no, there's nothing in the arm. As soon as it crosses the elbow, it's going to supply pronator teres, flexor carpi radialis, palmaris longus, and FDS. Now, again, remember I was telling you, rule of thumb, median nerve pierces the two heads of pronator teres, site of compression, pronator syndrome. So before it goes through the two heads, it's going to supply pronator teres. Remember that. And then as soon as it comes out of pronator teres, it gives off anterior interosseous nerve, which is a pure motor nerve, and it supplies FDP to first and second finger, index and middle finger, flexor pollicis longus, and pronator quadratus. Yeah. And then median nerve runs in the forearm, stuck on the undersurface of flexor digitorum superficialis. So if for some reason I have to look for median nerve in the middle third of arm, in case of a stabbing or a trauma injury, I don't go looking for the nerve. I go looking for flexor digitorum superficialis muscle, because that's easy to identify. You can flex PIPs and you'll know which muscle in the forearm is FDS. And then when you see the undersurface of FDS, that's where you find median nerve. And 5 centimeters proximal to the wrist, median nerve divorces FDS, becomes very superficial, comes to lie between FCR and palmaris longus, and then it will enter your wrist joint. And obviously 5 centimeters above, it gives a cutaneous branch. Then once sort of it crosses the carpal tunnel, a deep motor branch. Deep motor branch will supply your loaf muscles. L, lumbricals, first and second. O, opponens pollicis. A, abductor pollicis brevis. F, flexor pollicis brevis. And then, of course, the sensory supply to 3.5 fingers, as you can see in this picture here. Important here is abductor pollicis brevis. So when you think of thenar muscles, when you see a case of carpal tunnel, think of only one muscle, abductor pollicis brevis. This is one muscle. One, it is responsible for abduction, which helps in opposition. Two, this is the only muscle which is purely supplied by median nerve. And the other two muscles also have contributions from ulnar nerve. So thenar muscles, median nerve, carpal tunnel equals abductor pollicis brevis. Bit about carpal tunnel anatomy, you can be shown a cross section. It's not a true representative, but very sort of near normal. So FDS are arranged in two pairs. They're not, and FDP is in one single line. Remember that. Ulnar nerve is slightly radial to the FDS, not that radial, but slightly radial. And then you have flexor pollicis longus. So 9 tendons and the nerve. FCR has its own sheath. It's not part of carpal tunnel. Causes, I used to think when I was doing exams 8 or 9 years back that carpal tunnel may have 10 or 20 causes. I could find 150 causes. I've just included it to tell you that you need to know at least 8 or 9 causes. It's a bread and butter topic, and we need to know these causes. So I prepared this mnemonic: pragmatic. Most common cause is idiopathic, which is not here. So remember that. Then pragmatic, P, pregnancy, rheumatoid, acromegaly, G, glucose diabetes. Mechanical is all your lunate dislocations, ganglions, lipomas. A is your storage disorders, T, thyroid, hypothyroid, infections, and your gouts and pseudogout. So idiopathic, pragmatic, and if you are able to tell all these causes and you're doing very well, examiner can ask you a congenital cause. So lumbricals we saw before, they're coming from zone 3. But if they have a slightly proximal origin in zone 2, zone 4, that is under the flexor retinaculum. If they come from FDP under the flexor retinaculum, so it becomes a space occupying lesion. So patient will get a carpal tunnel, or a accessory palmaris brevis, or a anomalous duplicated FDS. Again, if it's a duplicated or accessory FDS, it creates, there's not enough room under the carpal tunnel. So hence space occupying lesion, hence the symptoms. So causes are important. They will expect you to know all of them. Then in terms of presentation, sensory symptoms, we know 3.5 fingers, autonomous zone, volar pulp, index finger. That's where you do your sensory exam. Nocturnal symptoms, very important. So patients with carpal tunnel typically get up in the night and they shake their hands to get rid of it. This is one question you need to ask to your patients in the exam and in the clinics also. Monofilament test and 2-point discrimination, you need to know, especially in the diabetic patients. And then thenar muscle atrophy, fine. Now, important again is, as I said, thenar muscles, think of abductor pollicis brevis, because that is the muscle where you will do your tendon transfers. And other thing is, if the muscles are severely atrophied, thumb opposition. Thumb opposition is a composite movement. Let's see if I can show you. So it starts with thumb abduction. Let me do it. No, I think this is better. Thumb abduction, that's abductor pollicis brevis. And then flexion happens, and then your thumb is pronating at the same time. So opposition again is abduction, flexion, and pronation. Flexion is a pure movement which happens at MCPJ to the thumb. But abduction, flexion, and pronation are all happening at CMCJ. So please remember opposition. So the initiator of opposition is abduction, abductor pollicis brevis. And that's why I'm emphasizing on that. And with such severe atrophy, patient won't be able to abduct because there's no abductor pollicis brevis. So what they do is they use their extensors. They do side sweep, pronate, and try and oppose. Side sweep, extensors, pronate, and oppose. So obviously in an elderly person is fine, but in a middle-aged woman or a man, commonly women, it's a bit of a handicap, and hence the tendon transfers. In terms of tests, Tinels, I told you do always at the end. Phalanx, but Durkin's is more important. Durkin's basically is you palmar flex the wrist, and then put some digital, like direct pressure onto the carpal tunnel. Durkin's has the maximum sensitivity and specificity of around 85 to 95%. Once you've done this, now this I've just included, but I'm not going to spend time on this. You can be given a nerve conduction study from your neurophysiologist in the exam and asked to read about it. So please in your hospital see that. And you should know about sensory latencies and motor latencies. Read up on those guys. Again, so you've done your nerve conduction. Another little thing to add here is sometimes I notice nerve conduction studies are normal, but patient still has symptoms. So in those cases, I would always get an ultrasound scan to see the quality and texture of nerve, to see the thickness of nerve. And even on scan, if the nerve is thickened, if the texture is not good, if the nerve looks dull, I would treat them as having carpal tunnel syndrome, and I would ask my radiologist to give a steroid injection. Management, again, mild cases, splints. Splints again. So what happens is, as you know, with phalanx, the moment we palmar flex, it increases pressure in the carpal tunnel. So splints is to keep the wrist straight, especially when they sleep. Splints are very effective in mild cases. Steroids we've spoken about. Surgery, again, I do an open carpal tunnel release, but you need to know 1 or 2 lines for endoscopic carpal tunnel release as well. Endoscopic can be 1 or 2 portal. Important with endoscopic is you need to make sure, because you're going to put a big endoscope in a carpal tunnel, which is already diseased, median nerve doesn't have a lot of space. So you need to make sure or rule out any lipomas or tenosynovitis to the tendons in the carpal tunnel. So get an ultrasound or an MRI scan. And then of course, because you're putting an endoscope, there's a small chance of damage to the median nerve, or you may not be able to release it completely. So just some pros and cons to bring about in the exam. Open carpal tunnel, again, because we do it so often, this can be asked in the exam. So first is this cardinal Kaplan's line. So thumb extended, line from there, hook of Hammett, so 1 line. Second is from your middle and ring finger, draw a line back. So this point is Kaplan's point. That's where the recurrent motor branch is given. And then your wrist crease. Other thing is steps of carpal tunnel. So you're going to go through skin and fat, palmar fascia, which is your longitudinal glistening fibers. Then your transverse carpal ligament, which are horizontal fibers, and gritty. You feel it when you cut with a knife. And of course, when you're going through transverse carpal, you always look for recurrent motor branch in case it's coming out through the ligament, transligamentous branch. Other question can be, so Kaplan's point is where your deep palmar arch is. So in the exam question is which arch will be damaged, deep arch or the superficial arch? So even though deep arch is here, where my arrow is, but as the name suggests, it is deeper to all the tendons. So to cut the deep arch, you have to go through all the tendons, which is not possible. That's why it's the superficial arch, which is a centimeter forwards. This is the arch to go. So by mistake, when we are releasing the distal sort of transverse carpal ligament, if the scissors go a centimeter forwards, superficial palmar arch can get damaged. And this is the reason, if you do carpal tunnels with a tourniquet, always take it off before you stitch the skin. If by chance the nerve is damaged, then idea is to extend your incision distally and ligate the arch. Very important. Other thing to remember is variations, motor branch variations, palmar cutaneous branch variations, superficial palmar arch damage I've told you about. So if you see median nerve, transverse carpal ligament, 4-5 centimeters, that's where the palmar-cutaneous branch to your thenar eminence is given off radially. And recurrent motor branch is extra ligamentous at the Kaplan's point, where the transverse carpal ligament finishes. Now, if I bring you back to this picture, so this is where we are incising the ligament. Median nerve is here. Palmar-cutaneous branch is given off radially, and then it supplies the thenar eminence. So if you're cutting your ligament, sort of your ring finger radial border, you save your palmar-cutaneous branch, because it's you can't see it when you're doing your carpal tunnel decompression. And amongst all the cutaneous nerves, palmar-cutaneous branch is the one where neuromas are not troublesome, where you get away. Whereas superficial radial nerve cutaneous neuromas and dorsal cutaneous nerve neuromas are very disabling. So remember that difference and how to save it. Then recurrent motor branch variations, as we said, this is most common. Extra ligamentous, 50%. This is the one which is coming from the ulnar side. And this is the one which pierces the ligament itself, 20% transligamentous. And then under subligamentous is 30%. So just remember these variations. Then, so we finish carpal tunnel. Then the tendon transfers for low median nerve. We're not going to do high median nerve today. We're not doing pronator syndrome today. So for carpal tunnel. So as I just showed you in the last picture, severe wasting, sideways swipe of the thumb, sideways swipe using extensors, and then using your pronation to oppose. So it's very disabling in middle age. In my practice, I would do maybe 2 cases where I would do a tendon transfer. No middle-aged women, so I use a palmaris longus, a Chemet's transfer, because you're not burning any bridges by using your palmar fascia. So aim is to restore thumb opposition. Now we know it's a composite movement. We know initiator of thumb opposition is abductor pollicis brevis. And we have various options. As I said, Chemet's, this is what I would do using palmaris longus. Thompson's is FDS. You can use abductor digiti minimi, extensor indicis proprius, whichever like you prefer in your practice. Pulleys. Now this is another very fascinating thing in hands. We've got lots of pulleys. Basically what pulley does is it changes the direction of your tendon, changes the vector of the pull. So it makes your tendon very efficient. For example, in hands, you have sesamoids in the thumb. You've got pisiform where FCU is attached. You've got hooker hamate. So we've got lots of pulleys which sort of your tendons go around those and they become very efficient. I'm not sure, but maybe some of you or one of you, few of you may have been to sort of hospitals where like 20 years back, 25 years back, patients with femur fractures were managed with plasters with pulleys overhead. So the whole purpose of pulleys was to make the whole system very efficient using less energy. So Chemet's transfer, again, main aim is for abduction, palmar abduction. So we're going to take palmaris longus. Now key here is this is palmaris longus. Make sure patient has one before you consent them and put them to sleep. Second, we know palmar fascia. Now to do a carpal tunnel, we go through fascia and transverse carpal ligament. So if you are committed to do a Chemet's transfer, please don't do carpal tunnel. Just do skin and fat, look at the fascia, and then take a strip like we've shown here. Take a nice strip, the width of your tendon, nice strip of your fascia. And other thing to remember here is because palmar fascia will stop in the palmar crease there. And we have to swing this across here to abductor pollicis brevis, to MCPJ. So so you just about have enough length to swing across. So you need to go as distal as you can, fashion your fascia, make it into something which looks like a tendon, and then another small cut at the MCPJ. That's where abductor pollicis brevis is, and attach it there. So if you see your incision is right up to from the palmar crease up to 3-4 centimeters proximal to your wrist crease. Nice tendon, swing it across, and then attach it to abductor pollicis brevis. Then complete your carpal tunnel decompression here. Other thing is a pulvar-taft weave. There's another question you can be asked in the exam. Now these tendons are very small, so you can't do a pulvar-taft weave here. All you do is wrap it around APB and put some stitches, 5 or 6 or Prolene, whichever you have on your shelf. But for bigger tendons, for your Vaughan Jacksons, for FDS to FPL transfers, radial head tendon transfers and palsies, you need to know pulvar-taft weave. Other thing, pulley. So in this picture, they've not made a pulley. You can do a palmaris longus without a pulley, but if you want to, once you cut your transverse carpal ligament, make a small hole and pass your palmaris longus through it. Obviously, ulnar side will be better because you have a better vector of pull. Thompson transfer, I've never done one. FDS to ring finger. Now, for all my work, whether I'm doing Vaughan Jacksons or sort of FPL ruptures over distal radius plating, I will always take a FDS to ring finger. So, so that's your ring finger FDS. You take it off just before it divides into chiasma. Now, in pronator, in sort of pronator syndrome, in the next lecture, I've got lots of my operative slides where I've taken FDS. So I'll show you the incisions, how like sort of operative pictures. But for today's lecture, we'll just go through this diagram. So that's where A1 pulley is. That's where chiasma is, just 2 millimeter before to get the maximum possible length. Then what they've done is FCU, you take half of it, loop it back, make into a small pulley like they've shown there. FDS goes through the pulley and then attaches again to abductor pollicis brevis. So you can see whether you do a Camet's, you do any transfer, Camet's, Thompson, Hubert, anything, insertion is always to APB at MCPJ on the radial side. Pulley again to, because if you have a pulley now, the direction of pull will be such that thumb will be abducted. Once is abducted, so again, once with my tendon transfer, my thumb is abducted, my flexor pollicis longus, which is supplied by AIN, which is intact, will flex the thumb, and then little finger can come to my thumb, and I can do the opposition. Abduction, tendon transfer, FPL, and little finger or ring finger. So that's how these patients will do opposition. Finally, Burke-Halter transfer is EIP to APB. Again, I use EI for rheumatoid patients, for EI to EPL transfers. I've never done one to APB, but just for completeness sake, for exam purposes, EI ulnar tendon. So make a small cut in retinaculum. How do you make sure this is EI? So fourth extensor compartment has got EDC and EI. EI is the only tendon which has a bulky sort of muscle close to extensor retinaculum. So if you see muscles, you know that's EI, not EDC. So once you've confirmed, you cut EI, you take it out proximal to extensor retinaculum. EI comes from ulna, so it's an ulnar muscle origin. Another cut on the ulnar side, EI comes out, that's the same cut, subcutaneously reroute it, and then again, like any other transfer, you've attached it to APB. So you can see again the direction of pull is such, thumb will go into abduction, and then FPL supplied by AIN will flex it, little finger can come close to it, and this is how they oppose. So, and I think, yeah, that's pretty much it for today. So we've covered today ulnar nerve in entirety and median nerve at the wrist level. Next lecture, I'll cover, in fact, I have slides already there I can show you. Next lecture, we can talk about pronator syndrome, AIN syndrome. What's the difference between the two? All the tendon transfers. These are my operative pictures where I've taken FDS. So tendon transfers, pulvar-taft weave, and then we'll go to radial nerve. supinator syndrome, and some of the operative pictures. So that we'll cover in the next lecture, guys. So
Absolutely brilliant lecture, Saurabh.
no, thank you, thank you, Dr. Hitesh. Are the candidates still there?
Yeah, they're all there.
Oh, fantastic. I just wanted to say one more thing. As I was saying, these nerves, they're very relevant because orthopedic surgery is only about two things: anatomy knowledge and how you handle nerves. So, and we all decompress these nerves day in, day out. We all do approaches day in, day out. So important is to know the course, to know the muscle supply. Tendon transfers are very, I'm sure you guys do much more than I do here for leprosies, for polios, for nerve traumatic damages. So it's a relevant topic, guys, for exam point of view and practical point of view. In the end, I'll just say good luck for your exams and thank you for your time and attention.
Saurabh, if I give you 1 more hour, I'm sure you're going to finish the entire upper limb. I know you're that passionate about your lectures. Thank you so much for coming in. So a couple of questions before we wind up. I know it has been positive and you're tired.
No, not at all. Please tell me. Pleasure.
Okay. See, the one thing is, when we talk about ulnar nerve neuropathy at the elbow, there we talk about the supracondylar process, the ligament of Struthers, right? So is it for the pronator? So what happens is there's a lot of overlap. You talk about when we talk about Osborne's fascia for the ulnar nerve, and sometimes the ligament of Struthers we implicate for both the ulnar as well as median. So what is your take on that?
So see, as you were saying, so that's your supracondylar process. And then there's a ligament which comes from there to medial epicondyle. But ulnar nerve is behind it. It's a posterior structure. From what I'm aware of, it is not, I've not heard of ligament of Struthers causing ulnar nerve compression, personally at least.
Only the Osborne's fascia.
Only the Osborne's fascia. Because we can see here, that's the supracondylar process. It's just a spur seen on an X-ray. Ligament will go from this spur to medial epicondyle. So median nerve will pass below this, as you can see there. Ulnar nerve is a posterior structure, so it shouldn't come in the way.
And what about the two heads of the FCU?
Yes, two heads of FCU, ulnar nerve gets compressed. And that's why would you like me to take you back to those slides?
No, it's okay. You can just enumerate here.
Okay.
You have to go all the way to the front.
So exactly. So yes, that's where it can get compressed. I have seen a lot of ulnar nerve issues for Osborne's ligament or behind epicondyle. So far, FCU arch, I've not seen it causing a compression, as opposed to arcade of Froche in supinator. That can cause problems to pin. But ulnar nerve, theoretically, yes, practically, I've not seen one.
Okay. And you have told about ulnar nerve transposition. So which one do you prefer? Is it submuscular?
No, submuscular is so there are 2-3 problems with submuscular. You have to take off all the flexors and reattach it. Second, you're very close to median nerve. Third, it doesn't serve, like, unless nerve is really short for some reason, or like it's a 3rd, 4th revision, subcutaneous will do the job. I try and avoid transpositions because the moment you devascularize a nerve and moment you handle and start fiddling with the nerve, it becomes irritable, it causes neuritis. So I was doing an elbow replacement last week with a colleague of mine from King's. Even then we didn't transpose it, even though most of the elbow surgeons would have. And if I have to, I would do an anterior transposition subcutaneous. So what I do is take a fat pad flap, put the nerve in between 2 layers of fat and 3 pockets, 3 stitches. So,
and do you combine with the medial epicondylectomy?
No, again, very rare. Unless I see some spurs or problems with epicondyle, it's hypertrophied, I will not excise it.
Okay. The other question is regarding the tendon transfers for ulnar nerve. So your preferred procedure is the Zancoli's lasso. Am I right?
For exam purpose, I kept it simple. So what happens is, technically, if you speak to hand surgeons, when you give them a Bouvier splint to keep MCP flexed, if patient is able to extend eyepiece, then you can do Zancoli lasso. If you give a Bouvier splint and patient's fingers remain flexed because your interossei are gone, your IPJ extensors are gone, and your extensor muscles, your EDC is so weak it can't extend it, then you have to take FDS, divide it into 4 slips, and put them at the lumbricals, at the extensor hood.
So that's
Which
the
is
modified
transfer.
is the modified Stills Bunnels transfer, is it?
Yeah, it's a Bunnels transfer. I didn't want to say that deliberately because it confuses matter. Zancoli is good enough in the exam. If you can talk about Zancoli's lasso technique, Bouvier's splints, good enough.
Saurabh, is the Bouvier splint same as the knuckle bender splint? Basically, you're looking at MCP joint flexion, isn't it?
Any splint which flexes MCP is a Bouvier splint to me. You can call it any name.
Okay, because there is a, I remember there's a knuckle bender and there's also a reverse knuckle bender splint, if I'm
Correct.
not, if I'm right.
So there are many different shapes, names, but idea is to recognize this splint is to keep MCPJ flexed.
Also, when you do a Zancoli's lasso, do you do a dermodesis along with it? I mean, remove the skin and cause so that MCP is in flexion?
No, it's very simple, but no, I don't. Some people talk about tenodesis, I think volar plate tenodesis or something, but that's static. With time, it will stretch out. Tendons is dynamic. It's a very straightforward procedure. Technique, key point here is you're taking one FDS, dividing it into 4 slips. So to do that, you have to remove the synovium across the tendon. Otherwise, it will never split nicely. So denude the tendon of any synovial lining and then hold it with 2 very fine artery clips and divide into 2 first. Then take 1/2, divide into 2, 1/2, divide into 2. And then passing it across A1 pulley is nothing really.
And you're removing it proximal to the campus chiasma.
Yes, just 2 millimeter because you need length, enough length. And the reason it's so very close to chiasma is it may prevent swan neck deformity in the future.
Exactly. That's my question. Next question is, are you concerned about the PIP joint swan neck when you do a Zancoli's lasso?
Am I concerned about?
The swan neck deformity by doing a Zancoli's lasso procedure?
Not really. One, I don't do enough to give you educated answer. Two, bit of swan necking doesn't matter because we know with mallet injuries, swan necking can happen. But unlike a rheumatoid, it's not a big problem for function point of view.
Okay. The other question is regarding the endoscopic carpal tunnel release. I mean, there's a lot of data to say that the chance of a nerve injury is higher with the endoscopic carpal tunnel. So do you think it's just a marketing sort of campaign?
Personally, I feel so. I've done it on cadavers again for completeness sake. By the time you do a 2-portal endoscopic carpal tunnel, if you join the length, it's as good as your carpal tunnel length. You're taking all the risks. It's very cumbersome. You may not release it adequately, damage to median nerve. You have to get a scan to rule out any space occupying lesion in carpal tunnel. Personally, I'm not a big fan. I feel it's more of a marketing gimmick. A gimmick, you can say, or if you are a pure hand surgeon and do nothing more, and you're doing hundreds of carpal tunnel a year, fine, you may get better at it. Does it have a big advantage? Answer is no. I don't think so personally.
And before you do all a nerve surgery, you get a nerve conduction and EMG studies always, isn't it?
Yeah, I always do for medical legal purpose because if the symptoms don't settle, especially working in London, then I can repeat a nerve test to show that you had severe compression to start with. It shows your flow of current has improved, but your numbness was never going to get better than more than 40%. So I will always get one. Unless patient is very old with lots of medical issues, then I do a thorough documentation and I'll do it without a nerve test.
And how often have you encountered a double crush? For example, a patient has a cervical spine coexisting disease and a carpal tunnel.
You will get in elderly people, especially with shoulders, they almost 1 in 5 cases you'll have concomitant neck problems and shoulder problems. Is there. Carpal tunnel, I must say, I've not shoulder lots of time, despite arthroscopic SAD, they will have persistent symptoms and I warn them. Carpal tunnel, I must say, because remember, carpal tunnel is 3.5 fingers. If something is coming from the neck, it has to be C6, which involves these 2 fingers, C7, even part C8. 3 nerves have to go to mimic complete carpal tunnel. So I don't think neck and carpal tunnel bothers me that much.
But you would always get a cervical spine X-ray, isn't it? You don't.
So I would always do a neck examination as part of my clinical checkup. If neck is severely arthritic, they have neck issues, then I'll get an MRI and I will warn them.
Okay. The other one is regarding the CAMETs that you mentioned. A brilliant demonstration. I mean, you've just really looked into the finer details. So the moment you have you're looking at a carpal tunnel with pinna muscle atrophy, you are planning for a CAMETs, is it?
Not again. See, elderly people, I wouldn't do a CAMETs. So I do a lot of carpal tunnels here in elderly people, but the reason being carpal tunnel, pure carpal tunnel, in 2 weeks they're fine once wound heals up, like they can get on with their life. Moment you do a tendon transfer, you have to put them in a plaster for 4 weeks. And then tendon transfer takes 2 to 3 months, like for tendon to take to each other. So it's a long rehab. So elderly people, which is most of the mid-inner problems, I wouldn't. That's why I was saying in the lecture, I'll do maybe 2 cases a year. My typical candidate is a middle age, 55-ish, 60, up to 60 women, not so common in men, who have a severe atrophy and a sideways sweep to do opposition. So middle-aged women are very few with carpal tunnel. So maybe 2 cases a year.
Okay, thank you, Saurabh. I think there are no more questions. You have done a fantastic job, completed the almost half of the upper limb neuropathies. And I'm sure all the guys are looking for the second part of the lecture, which you have already given a glimpse towards.
No, it's a pleasure. And yeah, once again, thank you guys for your kind attention and good luck. And thank you, Dr. Hitesh. Very grateful to you. Thank you.
Thank you very much.
Pleasure, Dr. Hitesh. Thank you.